We spend so much time talking about lifestyle changes, eat less, move more, all of it. But there's this really crushing moment so many people face. You've done everything right for 6 months. You've been hungry every single day, and the scale has, what, moved maybe 3 pounds?
It's the moment the math just stops making sense. And that's usually where people turn inward and blame themselves. They think, I must be doing something wrong, or, I just don't have the discipline.
Right. But what we're digging into today just turns that whole idea of self-blame on its head. We're looking at the biology of why that happens. And, more importantly, the two biggest heavy hitters in medicine designed to break that cycle. We are putting the new champion, GLP-1 medications like Ozempic and Mounjaro, head-to-head with the defending title holder, bariatric surgery.
Yeah, it's the injections versus scalpels debate. And frankly, this is probably the most rapidly evolving conversation in all of healthcare right now.
It really is.
Yeah.
And I want to start with the why, because before we get into the mechanics of gastric sleeves or weekly shots, we have to talk about the metabolic set point. It seems like our bodies are basically acting like a thermostat that's just stuck on a high temperature.
That is the perfect analogy. It's what we call set point theory. Your body has a weight range it prefers where it feels safe. And if you try to lose weight through diet alone, your body doesn't see that as, a health improvement. It sees it as a threat to its survival.
It thinks a famine is coming.
Precisely. So it launches a counterattack. It slows down your resting metabolic rate so you burn fewer calories just sitting there. And at the same time, it just floods your system with ghrelin, the hunger hormone. It's a biological double cross designed to force you right back to that starting weight.
Which is just devastating to hear, but it explains so much about why standard dieting fails so often. Your own body is working against you. So the whole point of our deep dive today is that we are not talking about willpower. We're talking about biological interventions that reset that thermostat.
That's the key. We're moving from a behavioral model of weight loss to a biological one.
Okay, so let's bring out the first challenger, the one that has completely taken over the cultural conversation for the last, 2 years, GLP-1s. We all know the names Ozempic, Wegovy, Mounjaro. But what is actually happening in your body when you take these drugs?
It's fascinating, really. It's biomimicry. Your gut naturally produces a hormone called GLP-1 after you eat. It's the signal that goes to your brain and basically says, okay, we're full, you can stop eating now.
But for people with obesity, is that signal just weaker, or is the brain not listening?
It can be a bit of both, or it just clears out of your system too quickly. These medications are synthetic versions of that hormone, but they are much, much more powerful, and they stick around longer. They don't just whisper, stop eating to the brain, they shout it. They also slow down how fast your stomach empties, so you physically feel full for longer.
But I think the most incredible part, and this is what I keep hearing, is the psychological shift. It's not just a full stomach, it's that the food noise just turns off.
The food noise concept is so important. For so many people, the brain is just constantly thinking about food. What's for lunch? Did someone bring donuts? I'm stressed. I need something sweet. It's like this constant background static. These drugs seem to quiet that down by targeting the reward centers in the brain.
Like unplugging a radio that's been stuck on static your whole life.
Okay, but let's break down the players here. Because there's semaglutide, that's Ozempic and Wegovy, and then the newer one, tirzepatide, Mounjaro and Zepbound.
Right. Think of semaglutide as the first generation of this new wave. It targets one hormone receptor, GLP-1, and it's incredibly effective. The clinical trials show people losing around 15 to 17% of their body weight.
Which is huge. On a 200-pound person, that's 35 pounds. That's enough to seriously impact blood pressure, joint pain, everything.
Absolutely. But then tirzepatide came along. It's a dual agonist. It hits the GLP-1 receptor and a second hormone called GIP. So you're basically hitting the metabolic system from two different angles.
And I'm guessing that second angle makes a big difference? It really does. The data for tirzepatide is showing weight loss closer to 20, sometimes even pushing 25%. That is starting to get into territory that, until now, was only possible with surgery.
And that's exactly why we're having this conversation. But, and this is a huge but, right? There's no biological free line.
No, you definitely don't get one. The side effects are real. Because you're slowing down the gut, you get, the logical consequences. Nausea, heartburn, constipation, sometimes vomiting. For most people, it gets better as their body adjusts, but for some, it's just too much.
I've also read a lot about muscle loss. If you lose weight that fast, it's not all fat, is it?
That's a major concern, yes. If you're not really focusing on protein intake and resistance training, a big chunk of that loss, sometimes up to 40%, can be lean muscle, and that can leave people, especially older adults, feeling weaker.
And then there's the biggest catch of all. This isn't like an antibiotic you take for 10 days and you're done.
That is the forever factor. The data is crystal clear on this. These are chronic treatments for a chronic condition. If you stop taking the medication, the appetite comes back, the food noise turns back on, and the weight, it usually follows. One major study showed people regained 2/3 of the weight they lost within a year of stopping.
Which makes the cost just terrifying.
Yeah.
If your insurance doesn't cover it, you're looking at $1,000, $1,200 a month forever. That's a car payment or a mortgage payment.
It creates a massive equity problem. We have this incredibly effective tool, but right now it's mostly available to people with great insurance or a lot of money.
Okay. So on one side, we have a weekly, very expensive, probably lifelong medication that hacks your hormones. Let's turn to the other corner. Bariatric surgery. This has always been framed as the nuclear option.
It's invasive for sure, but it's also the most effective and durable treatment we've ever had for severe obesity. With surgery, we're not just hacking the software, we're fundamentally changing the hardware.
Let's break down the two main types because I think they get mixed up. The sleeve and the bypass.
Right. So the gastric sleeve is what we call a restrictive procedure. The surgeon goes in and removes about 80% of the stomach. What's left is a narrow tube shaped like a banana.
So you physically cannot eat a large mole.
Yeah, exactly. But there's a hormonal piece, too. The part of the stomach they remove is where most of that hunger hormone, ghrelin, is produced, so you get a smaller gas tank and less of an urge to fill it up.
Okay, that's the sleeve. Then there's the gastric bypass, which sounds way more complicated, like a major plumbing reroute.
It is. With a bypass, they create a very small pouch at the top of the stomach, about the size of an egg. Then they reroute the small intestine to connect directly to that little pouch. So food completely bypasses most of the stomach and the first part of the small intestine.
So you get the restriction, like the sleeve, but you're also absorbing fewer calories because you're skipping a big part of the digestive tract.
Precisely. It's restriction plus malabsorption. And that's why, historically, it's been the gold standard. With a bypass, we're seeing patients lose 30 to 35% of their total body weight.
So let's just put those numbers side by side again. Tirzepatide is hitting 20 to 25%. Bypass is 30 to 35. The drugs are getting close, but surgery is still the king for raw power.
For now, yes, and it's a lot faster. Most of the weight loss from surgery happens in the first year, maybe 18 months. It's a very rapid, very profound change.
But the lifestyle changes with surgery feels
Yeah.
heavier. With the meds, you take a shot. With surgery, you have to chew everything to a pulp. You can't drink when you eat. It physically changes your relationship with food.
It forces a certain kind of compliance. For instance, if you have a bypass and eat something really sugary or fatty, you can get something called dumping syndrome. You feel nauseous, shaky, sweaty. It's your body's way of giving you very harsh negative feedback.
It's your body screaming, we don't do that anymore.
Exactly. And you have to take vitamin supplements for the rest of your life. Because you're not absorbing nutrients properly, you're at high risk for deficiencies in iron, B12, calcium. It's a lifelong commitment to monitoring that.
And we can't ignore the fact that it is surgery. There are real risks.
The risk profile is much, much better now with laparoscopic techniques. It's actually safer than having your gallbladder removed. But the risks aren't zero. You can have leaks, blood clots, and unlike a medication, you can't just stop. You can't put the stomach back together. It is permanent.
Okay, so let's put them head to head. You're the listener standing at this fork in the road. On the left, the meds. On the right, surgery. How do they stack up on something like sustainability?
Sustainability is maybe the most interesting comparison. With the medications, sustainability depends on access. Can you get it? Can you afford it? Can you tolerate it week after week? With surgery, the sustainability is, well, it's built into you. Even on your worst day, your stomach is still small. It's kind of a set it and forget it mechanism, at least to some degree.
What about the other health benefits? I was floored to read that a gastric bypass can put type 2 diabetes into remission almost instantly.
It is one of the most incredible things in medicine. We see patients leaving the hospital off their insulin before they've even lost a significant amount of weight. Rerouting the intestines just rewires those gut hormones in a way that can effectively cure the metabolic dysfunction overnight.
Do the drugs do that?
The drugs are excellent for managing diabetes. I mean, that's what they were originally designed for. But it's management, a treatment, A bypass can be a functional cure, sometimes for decades. If I have a patient with very severe uncontrolled diabetes and a high BMI, I'm probably leaning toward that surgical conversation.
Which brings us to the decision. Who is the right candidate for which path? Is it just a BMI numbers game?
It starts with BMI, but it really shouldn't end there. The guidelines are pretty clear. Meds for a BMI of 30 or 27 with a comorbidity. Surgery is now similar, BMI of 35 or 30 with serious conditions like diabetes. But the real decision comes down to the patient's psychology, their lifestyle, their fears.
Give me an example.
Okay, say you have someone who travels constantly for work, hates going to the doctor, and is terrible with routines. A Wegovy injection might be a huge burden. For them, surgery is a one-and-done intervention that travels with them.
And the opposite could be true. Someone who's absolutely terrified of anesthesia or has had multiple abdominal surgeries and has a lot of scar tissue.
Exactly. For them, the medication is a miracle. It's a powerful, non-invasive option that just didn't exist 5 years ago. And it gives you an off-ramp. You can try it. If it doesn't work for you, you stop. You can't unsleeve your stomach.
You know, there's one thing we have to talk about, and that's the mental side of this, the easy way out stigma. It feels like people in both of these camps get hit with this idea that they're somehow cheating.
It's such a toxic and unscientific narrative. We don't tell someone who gets LASIK that they're cheating at seeing. We don't tell someone with depression that an antidepressant is the easy way out of sadness.
Right. We accept those as medical tools for medical problems. But with weight, we're just so attached to this idea of virtue and suffering.
We are. And the truth is, neither of these paths is easy. Surgery involves a major recovery and a lifelong restrictive diet. The medications involve managing chronic side effects and a huge financial burden. These are just tools that level the biological playing field so that all the hard work you do, the diet, the exercise, can actually produce results.
There's also the psychological hurdle of such a rapid change in your body. We've all heard Ozempic face. But with surgery, the loose skin can be a huge issue.
It really can. When you lose 150 pounds, the skin's elasticity just can't keep up. You can have someone who feels healthier than ever, but they look in the mirror and see this reminder of their former self. The brain can take a really long time to catch up with the body.
So look into the future. This space is just moving so fast. Are we just going to see these two things as separate paths? Or will they start to work together?
We are already seeing them work together, and I think that's the real provocative thought to leave people with. Combination therapy.
A hybrid model.
Exactly. We're already seeing surgeons prescribe GLP-1s to patients before surgery to bring their weight down and make the operation safer. And even more common, we're seeing it as rescue therapy. Someone had a bypass 10 years ago, the weight is starting to creep back. Instead of a risky second surgery, you put them on a low dose of one of these medications.
So the medication becomes the long-term maintenance plan for the surgical tool.
Right. Or you could imagine a future where maybe we do a less invasive surgery and pair it with a lifelong low-dose medication. We're moving away from an either world to a how do we combine these tools for your specific biology world?
That sounds like true personalized medicine. Not just handing someone a pamphlet and saying, good luck.
It's finally acknowledging that this is a complex chronic disease that often needs a complex chronic solution.
So if you're listening to this and you've been stuck in that cycle of shame and diet and regain, the big takeaway is that the science has fundamentally changed. You're not fighting a character flaw, you're fighting your own biology. And for the first time, we have tools that can actually fight back effectively.
The most important next step is to have an informed conversation. Find a doctor, ideally an obesity medicine specialist, who really understands both of these options. Not a med spa that only sells shots, not a surgeon who only wants to operate, someone who can lay out the full menu and help you choose.
Knowledge is power, and in this case, it might just be the key to your health. Thanks for taking this deep dive with us.
My pleasure. See you next time.